the time to pause these programs. That's the big thing that we want to say. Just it's not the time to pause the programs, and here are some ways. Okay, good. Here are people. Good. Whew. Yeah, so it's just not the time to pause these programs, and here are some ways to think about moving forward despite the challenging times. Any other questions, just send me a chat in the Zoom. I'll see it as I'm going. Hi, everyone. Good morning. Hey, Eric. Eric, I was just talking about you. Hey, Lori. Nice to see you here. Hi, Robert. Got some of our good substance use navigators here. I think this is going to be a really good session for SUNS to think about how to advocate for these types of programs despite the very challenging COVID surge. So Sandra, Robert, happy you're here. Hey, Troy. Hi, Tambra. Nice to see everyone this morning. I hope everyone's having a good day, whatever that means in 2020. Not exactly sure what it means myself. But, Hi, everyone. Anything you're looking to get from today's session, feel free to put it in the Q&A ahead of time. Happy to hear from you. And just to get started, if you're on a computer, if you have the chat function on the phone, why don't you just shout out your name and what hospital you're from? We're so curious who's Emily. Use the chat. Make sure you're sending to panelists and attendees. Just say where you're from. Contra Costa. We love you since the beginning. Yeah, the OG, Contra Costa. St. Joseph's, Orange County. Great. Nice to see you, Troy. So much interesting work going on in Orange County right now. We're just meeting with the chapter lead for the Young People in Recovery group to talk about adolescent services in Orange County. So you should be hearing about those soon from BC, your regional director. Good Southern California representation today. Nice to see everyone. So if you're just jumping on, you can use the chat to tell us your name and what hospital you're representing or what organization. We were just, good morning. We just were in the Public Health Institute's Opioid Summit for the last 2 days, myself and some of my Bridge teammates here, and getting to talk to hospitals all over the country. So just this morning, I was talking to hospitals in Ohio and Texas. Everyone's really interested in what we're doing out here in California. So just know that just by being here today, you're part of something. You're part of the forefront. Hi, Patty. Nice to see you this morning. I was just on a call with our sustainability folks talking about your amazing ideas for your sustainability pilot. Patty, we're going to have you on here in just a couple months, sharing all those learnings. Patty's going to log off. She's going to be like, you didn't see me. Oh, hi, Ryan. Nice to have you. Great. Chief Medical Officer for Sharp. That's a big job. You must be really busy right now, Dr. Nicholas. Thank you for taking the time to be here. We're really excited. Les, as you know, your presenter today is really excited to be leading the Sharp implementation here. Anyone else joining, go ahead and throw your name into the chat. Tell us where you're representing from. We're going to get started in about 2 minutes, maybe 2.5, depending on how many other people I'm excited to say hello to. That list can be never ending, so at some point you might have to cut me off. Hi, Julie. Nice to see you. Julie, you have to send me a private message telling me how you're doing. It's been a couple months since we've chatted. Oh, hi, Leslie. Nice to see you. Thanks for bringing some people today. We're so excited to be working with Sonoma Valley. Great. Hi, Jolie. Oh, hi, Emily. I've heard a lot about you. I don't think we formally met from Josh Luftig and company. Nice to have you today. Anyone else joining? Go ahead and throw your name into the chat. Tell us where you're representing from. Got some good, hey Sandra, some good California Bridge representation here. We've got Sky Christensen, who is extremely hard at work on our brand new website, which is premiering any minute. I think I'm going to get in trouble if I say which minute, because you know how websites can be, but it's premiering any minute. So everyone be on the lookout for our brand new website. It's going to have all the resources that you need to make all of this work that we're about to talk about happen. Oh, hi, welcome, Ben. We love our residents. Sometimes our residents are the best advocates for our programs. They're kind of a hidden, yeah, Kevin's nodding, hidden source of power. Yes, next week we have a new website. Hi, Sherry. Sherry's our new Sun director. So I'm going to get this started in just about a minute. I'm going to give about a minute or maybe a little bit less for others to jump on, but just a plug for our Sun program. So the goal of this program today is to talk about how you can keep your implementation alive and kicking despite the COVID surge, and also to do some math basics and hear from Les and Kevin about the considerable work that they've done in systems and in individual hospitals. But just a plug for our Sun program. We have a brand new Sun director whose name is Sherry, who was a Sun in our first iteration of California Bridge. And she has a team of 8 Sun mentors who are expert peer navigators who are officially hired by California Bridge, working in hospitals, but doing coaching for us on the side. And they are so excited to hear from your new Suns or your existing Suns who just want some community. So please, if anyone has somebody at their hospital who's transitioning their position to become a Sun, or if you need help getting ready to post that Sun position, please reach out to us at any time here at California Bridge. Sherry has a team ready and excited to help you. So I think with the theme of California Bridge being ready and excited to help you, I'm going to kick this off here today. So my name is Elizabeth Keating. I'm speaking of moments away to be the clinical program director of California Bridge. Really nice to see some new and old names on the list today. And today we're going to be hearing from Dr. Leslie Mukau and Dr. Kevin Jones. I'm going to let them introduce themselves, but what I want to say as a way of introducing them is that they are both new to our California Bridge team in the role of regional directors, but not in any way new to implementing this reform in California. And I have just had such a delightful time getting to know both of them since I onboarded them in the summer to this program, and I'm so excited to feature them today. So go ahead and real quick, some housekeeping, Q&A as we go. So we have left some time at the end for questions, but please send questions. Let's use the Q&A function for questions and the chat for any chit chat that you want to share. Oh, hi, Eric, I just saw your message. And let's get started. So we will be following up with these slides and this recording a little bit after the fact. And this seminar does qualify for 1 credit of CME, self-report for physicians, self-reported for other practices. And that link will be available at the end. So, all right, I think that was my best New York City native pace of getting us through the boring stuff. And I'll turn it over. Take it away, Dr. Jones, Dr. Mukau.
Yes, good afternoon. It's great to join everybody this afternoon. Thank you to Elizabeth and California Bridge for putting this on. I'll say just at the beginning that Dr. Mukau and myself have no financial disclosures, just a whole lot of passion for this. And so I am Kevin Jones. I'm an emergency physician. I practice in the Sacramento area, a medical director at Sutter Davis, and also helping implement MAT across the Sutter system in Northern California, and joined California Bridge as a regional director earlier this year, and I'm happy to be here today.
Good morning, everybody. I'm Leslie Mukau. You can just call me Les. I'm an emergency physician and practicing in the El Centro Imperial County. And Kevin and I, we do not hold ourselves to be experts. We're both regional directors. But we have actually started some programs that are functioning well. And what we are going to talk to you about is also how you can start your program. Now, we recognize that, all of you are coming from very different and diverse areas and different backgrounds. Some of the information we are going to talk about will be, experienced by all and will apply to all programs. And some of the stuff we are going to talk about will be very different from some of the programs that you guys have or are going to have. And also some of the challenges we are going to talk about may be different. We've already talked about COVID now, and one of the things we really want to talk about is no matter what type of program you are going to have, there are going to be challenges and barriers. And we are going to walk over with you on how you can overcome those barriers. And especially if you can bring in, there are some other people you may not think are necessary to the success of your program. Those are the stakeholders. We want you to recognize who they are and how you can bring them so that they can work with you to have a very successful program. And we will also talk about how you can increase the number of X-Waivered clinicians in your program, how you can teach your nurses, and you'll find out at the end of this hour that nurses are going to be a very crucial component of your program. How do you bring them along? How do you educate them? So, those are the things we are going to talk about. And the barriers that you recognize, you'll be able to navigate around them. How and what are the possible workarounds? And what we'll do is, we'll only talk about 20, 25 minutes, and then most of the time we will be entertaining questions. And there are some of you who also have launched very successful programs. We will want to hear from you at the end of this presentation. Next slide, please.
So just briefly, we wanted to touch on some of the challenges that the pandemic has brought. As I think we all know, many of those challenges also are felt by our patients. Social isolation, loss of access to care, increased risk of withdrawal. And so, despite, some of the challenges locally in our departments or hospitals, we just really want to say, this is not the time to pause these programs. I think our patients need this more now than ever before. And so there is resources on how to continue this on the California Bridge website regarding treatment access during COVID-19. And so I just want to direct everyone there to get some resources if they need it for their hospital. Next slide, please. So we wanted to say in that same sort of vein is that, telehealth is a good option for maintaining MAT for your patients during this pandemic. There's lots of different resources in order to do that, different access points such as Brightheart, where buprenorphine can be started via telephone, and patients can be followed up outside of the department. And so I just want to sort of remind everybody that is an option for patients, especially with the decreased maybe access to maybe some of the local clinics or outpatient providers, that this really is a good option for follow-up for patients. As support that, there's not, urine toxicology is not necessary with every fill. And so this really provides the chance to continue this for them. The plan for medication access in case of quarantine, like many regions are going under stay-at-home orders. This allows treatment to continue, as well as, prepare for any sort of increased overdoses and decrease harm for the patient. So just something to consider. There's also telehealth resources on the California Bridge website on different areas to implement for your program. Next slide.
I want to pause for a moment here. We've got about 100 people on this webinar today. Curious if anybody has any pressing questions. We have Josh Luftig here who we can unmute, some other California Bridge experts. I want to see if anybody has any pressing questions that are on their mind about maintaining treatment that you do have going on during COVID. We know that this is this can be a very tricky space with that a lot of questions can come up. So we did want to leave some space today to ask those. If you're not sure what your questions are, we can also take them a little bit later in the session. So I'm going to pause for one moment. See, you can use the hand under the participants, or go ahead.
Can you guys hear me?
Yes.
Okay. Hi, my name is Dr. Larkin Hoyt. I'm a director of Sharp Mesa Vista and San Diego's outpatient programs and Sharp McDonald Center. It's our chemical dependency rehab hospital. We have a MAP program. We're working, trying to develop a bridge within our own health system. And one of the things I just wanted to validate when I was reading my some of the research was that there is it true that there is an exception to the registration requirement known as the 3-day rule, which allows a practitioner who's not separately registered for narcotic treatment to administer but not prescribe buprenorphine, and that they can only prescribe, the treatment can't be carried out for more than 72 hours. So i.e. they don't necessarily need the waiver if they're able to start the induction in an emergency department, but then like our chemical dependency rehab hospital could pick it up, and which we have data 2000 waivered physicians there to continue prescribing. So is that actually the case? Am I reading that correctly, interpreting that correctly?
Yes, I'll sort of respond and let Leslie respond as well. So understanding is that the 72-hour rule, for those that aren't aware of what you're referring to, is that patients that present to the emergency department for treatment, the buprenorphine can be prescribed in the hospital by providers without an X waiver, because that is given under the hospital's X waiver. And the 72-hour rule allows the patient to then return to the emergency department or hospital for subsequent buprenorphine doses within a 72-hour period, which will allow for bridging patients to outpatient follow-up. This could be over the weekend or a holiday. So that I will say that, as far as the 72-hour rule, many patients, especially now, are having difficulty with access even beyond 72 hours. And so a lot of times when they, present to the emergency department, every presentation, every, day the patient presents, it's a new emergency. And so I think, erring on the side of the patient and making sure they have treatment is the most important, as opposed to, living strictly to the 72 hours.
Yes, I agree. And that is a great question. And I would want to remind those clinical champions who are going to be starting soon, you may get resistance from some physicians initially, using buprenorphine for patients. Anyone with a license to write for Schedule 3 drugs, which buprenorphine is under, can use or write for buprenorphine in the institution, in the hospital, in the ED, or as a hospitalist for up to 72 hours. So that is a very important, question. Thank you so much for bringing it up.
So thanks. Drawing your awareness to the question from Matt Underwood, who's our clinical champion at Riverside Community Hospital. He's saying telehealth options on the website. Can you speak to options for insurance status? Anything you know about that? I'm also curious if any substance use navigators on the line have any experience to share on that question.
Do you want to tackle that, Kevin? Is the question asking whether you can get paid or if you can bill for telehealth? And the short answer is yes, you can.
Okay.
Yeah.
Go ahead.
There's different options to refer patients to. Some providers use like Brightheart, where they literally connect the patient with this telehealth service directly in the emergency department. And there is sort of limitations as far as insurance coverage, which they can actually go over with the patient in real time. It doesn't take very long. If there is certainly limitations, then the patient will know right there, and you'll know right there to possibly look at other options for the patient.
Okay. Okay, great. So I know that Dan Lasoff from UCSD was trying to get in there. Dan, if you're able to get to a place with a little bit less background noise, just send us a panelist message and we'll unmute you. Any other questions? Anything anyone wants to bring up? Again, the guide to telehealth. Hey, Dan. The guide to telehealth was just pasted in the chat by Amy Lundstone. And we are here. Our regional directors are standing ready to help you with telehealth and any reforms to your MAT programs you might be making due to COVID. Okay. Julie from El Centro says, we use an outpatient telemedicine resource called Pro Wellness to follow up. They are great. I've heard a lot of really good things about Pro Wellness in Southern California. So definitely follow up with questions about that. Okay, great. Well, again, continue to be a broken record, we are here for you to maintain your programs during COVID, whatever that needs to look like. So please reach out to us. And I will now let Kevin and Les move on to the crux of their presentation. Keep the questions coming.
Next slide, please. Okay, so you just got the good news that you've won this amount of money to start a program. How are you going to start a program? So one of the things you realize that you definitely need to make the CEO of your institution your friend. Now, most of you can go practicing for a number of years without having met the CEO. This will be a chance to meet him. He or she will be the person who will actually make things happen for you. There are many doors you will need to open that you may not know about. And some of the barriers we will talk about that you will come across, your CEO can be your friend. And also from the CEO's point of view, some of them actually get excited that their hospital has been chosen to do something as great as this. And some of them may actually want to let the media know, let their boards know. So definitely you need to let your CEO know about it, your chief medical officer. And of course, for those of you in the emergency department, you know that, nothing ever moves without the director of nurses saying yes. And the director of nurses talks to the chief nursing officer. So you need to let the chief nursing officer be on your side. You need to let them know what it is you are doing, why you are doing it, and you sit down together and figure out, okay, so we are going to do this. What do we need our nurses to do? How are we going to educate our nurses? And we will talk about that later on. Now, there are many hospitals where in order to give Tylenol, you need a policy, you need a guideline. So you need your chief of staff to be aware of what you are doing, because if there are policies involved, you may need to get there. Luckily, when I started my program, I was the medical director at that time. So it was very easy for me to be able to get some of these things started. Now, if you are the clinical champion, you are not the medical director, you definitely need your medical director to be on your side. He or she will move things for you. So you just need to have these important people be on your side. Now, from the pharmacy point of view and from some physicians' point of view, the moment you say buprenorphine, you are going to give what? I have a very friendly pharmacist. He's a very, very well-read guy, but he is a little bit on the conservative side. And the first time I mentioned to him that, hey, I need to have buprenorphine on the formulary, he kind of looked at me and said, for what? And you're going to let the emergency physicians use it? So, it took quite a while, but there are hospitals like mine that may want every new drug that comes in to be on the formulary. And if it's going to be on the formulary, you may need to meet the P&T committee. I think most of your hospitals have P&T committees, and some of you may not even have heard of them. But this is the chance that you need to go to them, discuss with them what it is you want to do. How do you want the drug? Is it just going to be the tablet? Will you also need the IV for certain, situations? So, you need to talk to them about that. And also you need to let your local pharmacies know, and I will let Kevin let you know why you need to talk to your local pharmacies.
So going back just a second, if your hospital does require a policy, there's multiple hospitals within the Bridge network that have created and implemented these policies. So if you need help as far as what that wording looks like, just reach out. We have those resources. In engaging your retail pharmacies, it's important to note that if you are an X-Waivered provider and you write a prescription for the patient, you want to make sure that where they go, they're able to fill that. And that's something that you don't want there to be any barriers for the patient being able to pick up the prescription locally.
Right. And we will talk a little bit more down the line about the referral clinics. And these are going to be very, very important to your program. If you are starting a buprenorphine induction in the emergency department, those patients need to continue the treatment somewhere else. And also, you need to have a good clinical champion. This is a person who is respected by the other physicians, so that, when he talks to them, they will sort of listen. You don't want somebody who may be saying, oh, well, yeah, this is something we may want to do, but you actually need somebody who is going to champion this, because this is going to take more than just one person. And also, if you are in the ED, if you are starting the program in the ED, there are patients you are going to admit to OBGYN, to surgery, to medicine. You may want some key physicians in those departments also be able to help you, be able to know what this buprenorphine is all about and what this MAT is all about. And also that goes back to the chief of staff there. You may actually want to walk over to the Department of Medicine or OBGYN, talk to them during one of their meetings, explain it is what the ED is trying to do and how each of them can help you. The substance use navigator, that's a very, very crucial piece, and we will talk about it later on. Next slide.
Yeah, just before we move on, a little bit of interaction from the crowd. I see the chat is being used pretty regularly in this chat. I'm wondering if you're near your keyboard. Go ahead and tell us what's been the most challenging piece of this. Is it buy-in from the C-suite? Is it pharmacy? Is it internal pharmacy, retail pharmacy, referral clinics, finding other champions, hiring your son, people with existing programs, or people working actively to get your program off the ground? What's been hard? Just throw it in the chat. It's not a formal poll or anything. Don't be shy. We've seen it all.
Well,
retail pharmacies, getting the MDs to use Butte, hiring your son. Yeah, couple more. C-suite. See, so just these first couple answers tells us what we know, which is Les already said this. It looks different everywhere, right? Everybody faces a little bit of a different barrier, but ultimately, we've worked pretty hard over here to make sure we have help for no matter what. Cutting through the red tape to get the grant accepted. We know a little bit about that over here at California Bridge, just a little. Stigma, getting buy-in. Yeah. Financial incentives, that's a hard one. Okay, so Kevin, Les, hopefully these chats, you kind of know who you're talking to here. The hospital director, yeah.
And I see a question from Lori, who said, for patients that are discharged with a prescription for buprenorphine, is it typically hard to fill? I think, yeah, that depends locally. We did have some barriers to us locally where we had X-Waivered providers start to write prescriptions, and then the pharmacy, for whatever reason, weren't filling those prescriptions because either they weren't checking correctly the patient's X-Waiver license, and so patients were getting turned away. We had to sort of notify the pharmacy that, hey, we have X-Waiver providers. You'll start to see these maybe a little bit more coming from the emergency department. So that might be one barrier, but it is probably different locally.
Right, and if I can jump in, that's definitely why we included this piece in here. Remember, we are practicing in very difficult times where narcotics are being scrutinized. So if for a number of years, your local pharmacies haven't filled in a prescription for buprenorphine, and then all of a sudden 20, 30 are coming in, that sort of, here's some alarm bells. And also, that's why it's important to talk to them and say, hey, by the way, we are starting this program. You'll be seeing a lot of these prescriptions. And by the way, the state is helping pay these prescriptions. And by the way, do you really, really want us to be putting in a date on all of them, even though the date is there on the computer? Please, help us. And don't reject these prescriptions. If there's an issue, you can call us at this number. So, things like that, and that will smooth things very well.
So thank you to the brave souls who shared your barriers. We've got you. Here's your next slide.
So referring to the point on collaborating with your local clinic, this is going to be key for your program as well as for just a successful sort of follow-up for your patients. I think important thing is to, one, identify what your different referral options are. In addition to things like telehealth, is finding that local clinic that could be affiliated with your hospital or hospital system. That could be a FQHC. That could be a local provider, potentially, that is just very passionate about this. And so the important thing, I think, is to identify at least one, maybe multiple clinics that are going to be important to refer patients to. And what the first thing that I did when I sort of identified our sort of local clinic was that, what is their availability for referral for the patients? Are they only open for a few days a week? And if so, that's going to make it a little bit more difficult for patients to follow up. Or do they intake new patients every day of the week, or maybe at least 5 days a week, and it's just sort of the weekends that you really have to kind of help bridge patients to the next week? And one, are they open to starting to receive these referrals from the ED? If they are, how is that process going to happen? Is it going to happen through maybe some fax over to the clinic? Oftentimes they would like to know the patient's information, what their diagnosis is, and then also how much buprenorphine that they were started on in the emergency department, so they can kind of know where to go from there. And where are they located in regards to the hospital? Is it close by to where maybe some of your patients that don't have good access to transportation are going to be able to get to? Or is it someplace far away that's going to be really difficult for those patients that don't have a car or don't have someone to get them there? Because then you might have to look at some other resources for them. I think another important piece is, do they have some wraparound services? I know our local clinic has, counseling for the patient that they offer, as well as Narcotics Anonymous meetings. They even have yoga sessions. They have a lot of different wraparound services that they're able to offer to the patient, in addition to continuing them, on treatment. Another important piece is, what insurances do they accept? Some clinics are, able to take all comers, including patients on Medi-Cal. Or if the patient's uninsured, do they have a process by which they can actually enroll the patient into Medi-Cal? Or has the clinic received maybe some sort of funding to be able to treat these uninsured patients. It's really, going to be important for the patient to kind of know that ahead of time so they don't get there and realize, oh, they don't take my insurance, or, there's going to be a gap in treatment while they try to get the patient enrolled in Medi-Cal. And that really kind of also speaks back to sort of the X-Waivered process and maybe being able to provide treatment for a period of time to allow for some of those maybe barriers that you have with the local clinic. And again, how will they receive referrals for the clinic? We initially started out with just a fax where we would have our ED nurse or ED secretary fax over a form with the patient's information, diagnosis, what we gave them in the emergency department. And then they were able to, at least they have the patient's phone number that they could follow up then with the patient the next day to make sure that they did know where to come, they did know where to follow up. More recently, we've worked with EDI or Collective Medical, which many of you might have in your on your EHR, to where we can link them directly, through our EHR to their EHR in the clinic. That takes a few more steps in being able to get the clinic on board with that referral process. And sometimes they're on a different EHR and they need to be able to kind of link that. And Collective Medical has been really good in being able to identify those clinics that are willing to do that. And that sometimes can make the process a little bit more easier and kind of takes out the fax process or some other steps. But those are some of the things that I think that I thought about. I don't know, Leslie, do you have any, barriers that you saw or important things with your local clinics?
Yeah, so actually, I agree with everything you've said. And I'll just add that, mine was a unique situation because I only had one group that I could refer to. And the problem there too was they only had one doctor to begin with. So they were sort of behind in actually seeing patients. And sometimes what they were able to do, and this is one reason why you need to talk to your clinics, because they are your fellow colleagues in this treatment. They would actually send some patients to the ED that needed buprenorphine induction because the doctor would not be able to get to them timely. And also discussing with them. In my group, we usually write a minimum of at least a week buprenorphine to make sure that the patients will have enough time, to be able to go to the clinic. So talk with your clinic, see what their capabilities are, see how you can help each other.
Yeah, remember to make it a, patient-centered referral process. So what's going to happen on the weekend? What's going to happen on a holiday? Make sure that you have some backup plans for that.
Good point.
Yeah, and I want to put in a plug, Josh Luftig, who's the California Bridge Director of Harm Reduction Services in the ED. He's putting a plug in for the Suns to play this role. I do want a couple Suns to weigh in on this toward the end of the presentation, but just know that everything that's on this slide should be navigated by your substance use navigator. And if they need help getting onboarded to do that, that's why we have our Sun Mentor team.
Absolutely.
All right, so you are the clinical champion, you've talked to your medical director, and the pharmacy says we need a policy. The chief of staff says, yeah, if you are going to start this SMART program, we need a policy from you. There are some institutions already here today who have these policies and guidelines for you. So if you feel like you need one, let us know, we will send you one. And actually, I just modified the CalSEP, policy and guideline. And that's something that we can give to you. And most physicians want to do the easiest, simplest thing that they can do. So your EMR today, you will find out that it doesn't have order for buprenorphine. You need to put that in. Work with your pharmacy and put the right orders in. The discharge instructions, you don't want the doctor looking all over the place for the discharge instructions. write them. And if you need examples of discharge instructions, let us know. We can give you some of those discharge instructions. You need to put them in your EMR, as well as the clinics that you refer to, make that a part of your EMR. You need to talk to the nurses, you need to educate them. And for me, and for most of you, you'll find out the best thing you want to talk to them about is what this program is all about. And then COWS, what the heck is COWS? How do you calculate it? What do you use it for? And after a few of these lessons, you will find out actually the nurses become your champions, and they will already do their COWS before the physician even does it. And then when the physician sees a COWS and said, oh, okay, why did the nurse do a COWS on this patient? Oh, there's that thing they were talking about, the MAT. Maybe I need to look into that. And what I did in the beginning is I actually started a newsletter specifically for the MAT program in my group. And in this newsletter, I would discuss how many patients we saw, how many patients qualified for buprenorphine, how many patients were able to go to the clinic, how many patients actually made it to the clinic. And guess what? I also sent my stakeholders the newsletter, the CEO, they loved it. They knew what was going on. And also for the clinical champion, this is your opportunity to know how the thing is working. You don't want to find 5 months later that, oh, none of your patients are following up. Oh, only 10% of eligible patients are getting buprenorphine. So if you have a regular way of doing this, this also makes it easy for you to have a handle of what's going on. Incentives, that's a very touchy subject, because you'll find out, in some of the grants, they tell you offhand, no, you're not going to have some of this money, pay for doctors to get X-Waivered. That's part of their education. But you can find little things of incentivizing people how to do these things. I started incentivizing people on, we started having a raffle ticket for those who did COWS, both physicians, nurses, and APPs. And I included the raffle winners in the newsletter, and guess what? My newsletter became very popular because guess where people would go to first? Let me see if I want something. So, think outside the box. There are many incentives that you can sort of, make people be aware of what's going on. And also at the beginning, we had a workshop where we invited all the physicians in the area so that they could know about the program we were starting. But more importantly, we started talking about this buprenorphine. You will be surprised. Buprenorphine has been around for a long time, but not many people know about it. And also buprenorphine has this mystique around it. Unless you had a fellowship in toxicology, you really don't get to use buprenorphine a lot, and you are scared about it. You think you are going to kill patients. You think that patients are going to have some adverse effects, but actually it's one of the safest drugs that we have. And I tell you, you are doing some stuff that's even more dangerous every day, and you don't even blink an eye. So the only way to let people know about this nice drug is to tell them about it. Hold workshops, let people, doctors in the community, nurses in the community. And I also actually invited religious organizations. You might say, why religious organizations? There are some organizations that are, trying to help people get off drugs, but they don't believe in medicines. They think maybe only prayers and abstinence will do it. But the evidence shows that that's actually not true. You need drugs to help with this. So invite them so that they can listen. and see what's going on. We invited the police. We invited the paramedics. All those are important stakeholders that you need cooperation from, and that they also know what's available. Next slide.
Yeah, and Les, a lot of people in the chat are asking to see your newsletter. So maybe if you can forward that newsletter to me, I'll include it as an attachment in the post-training email. That would be great.
Okay.
I have the privilege of receiving some of Les's of newsletters and mass communications, and they're great. He's great. You're going to want to be on his email list. So trainers, just for a time check, let's try to get through the rest of the material in about 10 minutes because I see some questions coming in that I want to get to. So keep in mind, Les and Kevin, I'm going to get in trouble from them for saying this, but they're available for you for any follow-up. I see a lot of people asking for that individualized assistance in the chat. You do have a regional director. If you're not sure who it is, contact me. We'll get you to them.
All right.
The big topic, getting people X-Waivered. What you got?
Right. So doctors and APPs out there, I am a convert. I was in the camp that says we've had enough about these merit badges. You know, we don't need any more ACLS, any more X-waivers, get rid of them. But after I took the course, I sort of put my tail between my legs because the course is very, very helpful. It tells you why we are doing it. It demystifies buprenorphine. It tells you about all the, I've been a physician, I've been working in the emergency department for close to 30 years. And I can tell you the way we've treated these patients versus how we are treating them now, it's a complete paradigm shift. And the only way you are going to go through it is to get X-Waivered. How do you get your doctors to get X-Waivered? I started with just 2, and those 2 X-Waivered providers in the ED, no one was writing buprenorphine. Then I started doing the incentives that we were talking with them, and no, we didn't pay people to get X-Waivered, but we incentivized them to. And pretty soon, they got X-Waivered, and I had a number of people in the hospital X-Waivered. And for the clinical champions, I will tell you, when you look at the charts for patients seen by X-Waivered physicians versus those not X-Waivered, the ones seen by the X-Waivered physicians are more likely to get buprenorphine and are more likely to be directed towards the clinic for further studies, whereas for the patients seen by the other regular physicians and APPs, they are more likely to come back either in overdose or dead. So I really am putting in a plug, do everything you can to get as many of your providers X-Waivered as possible. And if you can talk to me offline, and I can point you to some of the challenges we had and how we overcome them. And I don't know, Kevin, if you want to say something about how you did this for your group.
Yeah, no, those are great points, Leslie. Yeah, many of you maybe in previous grants were able to use some of that to help get providers X-Waivered, whereas, you know, or like myself, did not have that ability to kind of apply some funds for that from the group. I like the incentive, what Leslie brought up as far as maybe some sort of raffle. I think that's a good idea. And of course, always sort of going back to that, this is really the best thing for the patient. Doing a one-day online course, it couldn't be any easier. Saying that, you know, for the patient, that's going to be, you know, the best care for them that we're going to be able to provide is sort of getting that X-Waiver. And so, you know, I think sometimes it can be tough, you know, to get some providers or all of your providers X-Waivered, but, you know, the more you can, especially if you have multiple shifts overlapping for providers. If there's one X-Waivered provider, at least on at a time, that's going to be helpful at the very least.
Yeah, and folks interested in moving on this quickly, direct your attention to the chat. There's information from Rebecca Trotsky-Sir, another California Bridge Regional Director, founding member, about her X-Waivered trainings that are run through LA County. And we will have another large X-Waivered training happening through the Get Waivered ASAP organization in May. So it's a couple months away, but that will be coming. And I second what Les said. It's a lot more educational and, dare I say it, fun than your providers are going to think it is. So, all right. So move through this couple more minutes and then.
All right. This is just reminding you about the things we talked about. You need to bring everybody in, and you will be able to see further when you work together as a group. And we don't have time to go into the stuff you could do with the jails and the war and the community, but we can talk about that next time. Next slide.
Be the zebra and the giraffe. We love animals here at California Bridge.
All right. Again, I won't belabor this point, but this is incredible, guys. Buprenorphine. There are very few things in the ED that we do day in and day out that really make a difference. And for us, we now live in evidence-based times where everything you do has to have evidence behind it. And we need to know the thing we are doing, the drug we are giving, does it make a difference? Just remember that, for the ED, most of the things we do, we want an NNT. An NNT is a number needed to treat. In other words, how many patients do you need to treat before you can have benefit or before you can avoid an adverse effect? And usually if you have a number of 1 in 5, that's pretty good. Most of the stuff we do is maybe 1 in 15, 1 in 25. For example, the aspirin we give for coronary artery disease, that's 1 in 42. But for buprenorphine, if you are just giving 2 to 6 milligrams, your NNT is 1 in 4. If you go to a higher dose, up to 16 milligrams, it's 1 in 3. And if you are even higher, it's 1 in 2. And what are we using this for? Unfortunately, the study did not go into mortality. They were talking about retention in treatment and also avoiding withdrawal symptoms. So in the interest of time, I just want to let you know that, guys, we now have a very important tool in our hands. Let's use it. Next slide. Oh, okay. So, and I don't know how much time we have, Elizabeth.
Yeah, we just want to talk through these high level, and then we'll take questions.
Okay, so just briefly, just to let you know, if you are the clinical champion of your program, as we have said before, know your processes so that you can figure out if there are challenges somewhere or if things are going to go south. Be prepared to do something about it. The type of patients we are talking about do not want to be kept waiting in the waiting room. And I know there are most programs that even see them, they don't even bring them inside the ED. They see them out there, give them their buprenorphine. You don't need to be on a telly. You don't need any fancy stuff in order to give buprenorphine. Get to them quickly so that they don't go away. Recidivism, I now recognize that maybe that's not a word I should have used because that connotes some criminal element, but just know that most of these patients are going to be coming back time and time again. That's okay. You know, we have people with hypertension and diabetes who come time in and time again. I had some of my colleagues start saying, hey, I gave you buprenorphine last week. Why are you back today? Or we saw you 2-3 times again. You know, this is the last time. I need you to go to the clinic. No, just pause. This is a chronic disease. Just like hypertension and diabetes, people are going to be coming back, and it may take some time, a lot of times, for some patients to finally get where they are going. Make sure that they are following at the clinic. If they are not, figure out why. And one of the challenges I had in my area was transportation. The people I was seeing, they have no cars. They can't afford to get on the bus. They have no phone. They have no physical address. And again, this is where your son comes in. And what we did was we collaborated with the clinic we were sending them to. The clinic had cars that could go around and take them. But the way we could help was for the son to figure out, oh, so you live in the park. Which park, which part of the park do you live in? Oh, by the big fig tree. Okay, be there on such and such a day and such a time, and we'll pick you up. Or you have no phone. Do you have a relative or a friend who has a phone? Can we use that phone to find you? So those are some of the things you can improvise. And finally, beware the Ides of March. When we hear the Ides of March, we think of, oh, that's when they killed poor Julius Caesar. But actually, the Ides of March was when the Romans settled their debts. By the 15th of the month, or somewhere there, but everybody was supposed to settle their debts. You've been given a grant, there are deliverables. So the people who gave you the grant want to know that you are really getting some progress. So you need to send some deliverables back. So just remember, it used to be the 10th, but I think from John's last letter, now you can send your deliverables throughout the month. So just make sure you do it. And also when you do your deliverables, this is a great time for you to look at the numbers, see how you are doing as a program. There are times when you regress, that's okay. Find out why the numbers are low, find out what you can do about it. This is when you get to know everybody. Talk to your clinics. Hey, how many people did you see this month? The people we sent you, how many actually showed up? Who did, who didn't? And then get together and find out why. Next slide.
Great, yes. And as John is sharing in the chat, a clarification about BHPP data, in addition to expanding our SUN program recently, we were able to expand our resources on the data side. So any questions you have, please reach out to us about that. So there's at least one question I want to make sure to get to. So
Okay.
Kevin, do you want to breeze through, or is this you, Les?
Well, we were just wanted to, spreading the MAT gospel. There's lots of things to be able to, like Les said, creating some sort of pamphlet or newsletter. There's also resources for signage to place in your department, buttons to hand out to your staff, letting patients know, hey, we're here to help. And then, of course, things that you can share with your C-suite and community to let them know how you are addressing this issue.
Great. Okay, great. So this is us. We did it. So there's one question I want to get to because I think it's important for people thinking about framing their program, from Lori at Coast Plaza. And while we have Josh and Rebecca on as well, Josh and Rebecca, if you'd like to unmute yourselves, you can go ahead and raise your hand. Lori asks, why do you think buprenorphine is not used that often compared to naloxone? That's a question I've heard a lot. So I'm curious if one of the presenters wants to answer that.
Yeah, for me, at least at our side, it was much easier for the providers, much easier for the patient to start buprenorphine, also much easier for patients to get buprenorphine from the pharmacy. I know, going back to some of the pharmacy issues, while we didn't really have any barriers for the pharmacy stocking buprenorphine when we would prescribe them, finding, naloxone to be able to prescribe or trying to set it up within the hospital to be able to directly send patients home with that was much more difficult for us. And it's starting the naloxone or going that route is a little bit more difficult. Whereas, when the patient presents to the ED, in withdrawal, it's much easier to get them inducted on buprenorphine. From my, point of view. Leslie, I don't know, do you have any thoughts on
Right,
that?
that's actually a very great question. And like I said before, I think naloxone has been very successful because the harm reduction people have done a great job advertising it. And also on the buprenorphine side, honestly, not many providers know about it. And it is also, for those who know it, it is a drug that most people are afraid of. But actually, it's very useful. And the other thing that we didn't talk about, and we may talk about some other time, is there's an element in practice that feel that, giving these drugs, you are just substituting one evil for another. And when you take the X-Waivered course, that's when you'll find out, no, that's not really correct. You are not substituting, one narcotic for another. And that's not something I can go in great detail here, but that I think those, from my point of view, those are some of the reasons why buprenorphine is not widely used. And this is one reason why we are having meetings like this to spread the gospel. Buprenorphine is a great drug. Go on ahead and use it.
So we have the treat of having Rebecca Trotsky, sir, on the line, who wants to weigh in here. Before we let Rebecca talk, just a reminder, this is our blueprint. It's in the chat. Reach out to us at a time. These are all the things in the blueprint. And let's hear from Rebecca. And then I know we're going to start to lose people on the hour, but hopefully Les and Kevin have a few more minutes to stick around for your questions or any chatting you want to do. We're here for you. We'll stay until the last person has their next meeting. Rebecca?
Yeah, I just wanted to echo the bioavailable form of Narcan or naloxone is called naltrexone. That's available as an oral tablet or as a long-term injectable depot, kind of like a Depo-Provera shot. I completely agree with our other speakers that it's far more easy to start buprenorphine in the acute care setting than to start naltrexone to treat opioid use disorder. And it has the added benefit of treating withdrawal and pain when you start buprenorphine over the naltrexone. So happy to take any of these questions with our speakers. I'll be available, and I'm happy to help your institutions implement a very powerful X-Waivered training for your providers in your usual spaces that you hold training. So your grand rounds, your faculty meetings, things like that. I'm happy to be flexibly available to you guys.
We would love to come to all of your grand rounds and faculty meetings. Just call us. If you have not gotten enough of Les today, and I can't imagine how you possibly could have ever gotten enough of him and his expertise, Les, along with several other leaders, are going to be at this ACEP summit that's on the screen here next month. And then our series will resume the following month. So this is ACEP's initiation of BUPE workshop. Please consider attending that. It's 2 days, lots of our people, great primer on our model. And we will put the CME link in the chat as well as in the follow-up email. What else? What other questions do people have? Share them in the chat or raise your hand. We'll get you unmuted. And thank you, Les and Kevin, so much. I feel like this could have been 3 hours, and we could have had the same number of slides and just heard about your experience.
Yeah, thank you, everybody. And like I said, there are many successful programs out there, and people have done some interesting things outside the box. Just ask around. And you'll be able to find somebody somewhere who will be able to answer your question and help you.
Yeah, likewise. Thank you for having us. And it was great to just get together with everyone to talk about this. And I am available if anyone wants to reach out to me. I can put my email in the chat.
Yeah, thank you. Thank you for those of you who are saying this was helpful. Again, we can come and do this for your faculty meeting or your grand rounds. This recording will be available if you want to share with teammates. And just reach out to us at any time. There's Kevin's email. They're up on the screen. Yeah. Sorry, Eric, we didn't get to you and your referral expertise, but that is why we brought you on as a son mentor, so you can spread it widely. Thank you. We're here if you have any other questions. Caroline, I think we can stop recording.